I was really sad to see that our maternal mortality rate has been rising every year for the past 20 years. It had a big jump in 2021. The pandemic likely contributed to that. But the most recent data shows that the disparities, the racial and ethnic disparities in maternal mortality, are getting worse, not better, in particular for Black birthing people and American Indian and Alaska Native birthing people. And that is so disheartening because I know small armies of people working to improve equity in maternal health outcomes to see that they're getting worse for two groups is really alarming. Combining that with the erasure of maternal health data, we're seeing a lot of key public health data indicators that we rely on go away at the federal level. I'm thinking about PRAMs. And at the state level, several states have dropped their maternal mortality review committees. And those committees, the people who sit on those committees are physicians, public health experts. They review maternal deaths that happened in a state and pore through the data to try to understand why. What can we learn from these tragedies? What could have been done to prevent these tragedies? So that states are abandoning those committees is really concerning at a time when disparities are worsening.
We are really at I don't know what the word is, maybe I'll say pivotal point right now, where I think there's a lot of changes that are happening and a lot of dismantling of things that we knew that were effective, and without knowing like really what is to come in like a logical sense. So yeah, it is very disheartening, but I am glad that I know so many people that are continuing to work towards maternal and child health equity. And like to your point, like it is an indicator of a society of communities, like how we treat the moms and children and youth in our society is a real indicator of what our society values.
Yes.
It yes. No. So how can research be translated into policy to create better outcomes for mothers and children?
I love this question because I think research and policy, the research to policy pipeline can happen in several different ways. And it's really important, right? We want our policymakers standing on the shoulders of, oh, I'm going to edit that out. Poor metaphor. We want policy informed by research, right? Research tells us about what works, what doesn't, what can be scaled cost effectively and quickly, and what can't. And that is the information that we definitely want infusing our policymakers when they're deciding what programs to fund or support or invest in. I think, if you'll indulge me, story, I think there's two big ways that I, as a researcher, have been able to inform policy. I say inform, not guide, right? I'm not advocating. I'm just trying to share the evidence base with policymakers. That's an important distinction. One way was as a student, I took a class in cost effectiveness analysis. It's a skill I knew I wanted to learn before I graduated. And the question that we tried to analyze the cost effectiveness of was postpartum depression screening. What if we had to make, in a cost effectiveness analysis, you make a ton of assumptions to make your model work. So we assumed, man, Medicaid ends, this was years ago, Medicaid ends 6 weeks postpartum. So that first postpartum visit, you've had a baby, you have your first visit postpartum with your provider. That is the visit at which you could get diagnosed with something like postpartum depression, and then you immediately lose access to health insurance. So you could get diagnosed with something and then have no means to seek treatment for that condition. So we thought, wouldn't it be nice if Medicaid lasted the full postpartum year, when we know a lot of things can go off the rails in the first postpartum year for the health of a mom and a baby. So what if Medicaid lasted the full year? What if all providers valued maternal health? That includes pediatricians, primary care providers, and OBGYNs. What if they were all trained in and supported screening? Would that be cost effective to train all those providers, all of the providers, adding that to the way they do provide medicine? And we found it was wildly cost effective. And that was a class project, right? But I thought, oh gosh, I want this published. So I asked the professor if she would publish it with me. We did. It is my most cited paper. I'm so very proud of it. And 5 years after that paper, Medicaid is extended to a year postpartum in 45 states and counting. Providers, tons and tons of providers are screening for maternal depression. It's a whole conversation nationally. It's not nearly as stigmatized as it was. That can be so wonderfully fulfilling as a researcher when you see that your hard work was helped and supported that policy transition. But that took years, right? We know it takes a long time for policy to infuse practice. It can take decades even. There's also a much more direct way for policy to infuse research, and that is by talking to policymakers. There's a group that I've been a volunteer with for years, the Research to Policy Collaborative out of Penn, and they build relationships with offices, bicameral, bipartisan, state, federal. They talk to policymakers about what are the questions that are really important to your constituents, what's important to your community, what would you want to talk to a researcher about, and then they play matchmaker. And that has been incredibly fulfilling. I've gotten to talk to folks on the Hill, again, bicameral, bipartisan, talking to senators, representatives, Republicans, Democrats at the state and federal level. And that didn't take years. Those were brief conversations. And of course, I can't draw a line between what I said and what they did. But boy, does that make me a better scientist when I'm talking to folks talking to policymakers about what they're hearing from their constituents. That's not something I get to, I don't get a window into that often. So when I do, I think it makes me a better scientist.